Welcome back to the Family Docs Podcast, Treating Addiction in Primary Care series, brought to you by the California Academy of Family Physicians. By now, you've listened to the first episode, a look at why family docs are positioned perfectly to tackle MOUD, and you've listened to the second episode, looking at stigma, shame, and meeting patients where they are. So maybe now you're hooked? You know you want to get started with MOUD, but how do you start? On today's episode, Prescribing Medication for Opioid Use Disorder, our guest will explain the different medicine. Now there are 3, and really only 2 used in primary care, and guide you through very specific resources, protocols, so you can get started saving lives right away. We're joined today by Drs. Tipu and Rebecca Trotzky-Sirr. Dr. Tipu is a Primary Care Addiction Medicine Fellowship Program Director and core faculty, the Family Medicine Residency, as well as Adjunct Associate Clinical Professor at USC Keck School of Medicine, and Ventura Family Medicine Residency Program, UCLA. Our next speaker, Dr. Rebecca Trotzky-Sirr, is the Medical Director of the Urgent Care Center at LA County, USC, one of the largest public hospitals in the US. She is board certified in family medicine and addiction medicine, and is faculty in the Department of Emergency Medicine at USC. I'm thrilled to bring these 2 dynamic duos to you today. So Dr. Khan, take it away.
Hi, I'm Tipu Khan. I'm an academic family physician and addiction specialist at Ventura County Medical Center. And I find it really interesting as we try to work with young budding primary care docs, as well as those that are in practice, how we get them engaged, understanding how important it is that we treat opiate use disorder and substance use disorders as the disease it is. And that includes things like medication-assisted treatment. And today we're going to focus specifically on a portion of opiate use disorder that we use medications for, and we call that MOUD, Medications for Opiate Use Disorder. Rebecca, tell me a little bit about yourself, and I'd love to ask you some questions along the way.
Of course. Thank you. So it's so exciting to reconnect with you, Tipu. Both you and I got to do our residency at Harbor, UCLA, and you're a year ahead of me. So you're always like 1 year smarter than I am. Right now I'm at LACUSC, which is a safety net hospital in Los Angeles County, one of the larger medical homes for patients who really don't have any other resources to go to. In addition to being a family doctor, I'm addiction medicine certified, specialized, stamped with the seal of approval. And I've had the honor and privilege of working with a lot of great doctors across the state with California Bridge and a bunch of other learning collectives to help get the word out about buprenorphine and medications for addiction treatment.
All right, so let's get right into the questions. First question, Rebecca. When we talk about the treatment of opiate use disorder in clinic, we talk about office-based opiate therapy, using medications, MOUDs, to treat that. How would you describe OBOT to a new prescribing provider, like an intern, for example?
So treatment for addiction is one of the simplest medical decisions that I make in my busy day. And diagnosing it is, in my setting, pretty easily. So I would say that by the time a patient gets to see me in the safety net system, it's been a lot of many years, decades sometimes, before somebody has really recognized addiction in their lives. And there's really an advanced form of it. So we're talking about patients who tell me about injection heroin, using fentanyl, purchasing things in the street. The second I hear those kind of phrases, I know we have an opioid use disorder. I'm no longer on the fence like, I'm not sure if this patient's using opioids correctly, misusing them, or has an opioid use disorder. In other clinical settings, when I'm in a more of a well-resourced setting, you have some of those gray zones where you're like, this is a strange, baddie sense that I'm getting in my gut. And you're wondering, does this patient have opioid use disorder? And so then I often go back to, what are the uses and indications of opioids? Would I start this patient today on opioids? And if the answers to both of those questions are, I would never start this patient on opioids, and opioid therapy is no longer indicated, this is chronic non-terminal pain, the patient's not benefiting, and I've already tried working to taper down those opioids and it's failed, often that is opioid use disorder. And the beautiful thing about buprenorphine is it treats pain extremely well. It's a great analgesic. And it treats cravings and addiction and withdrawal extremely well as well. So when I'm on the fence and I don't know what I'm doing, it's great to have this tool in our armamentarium that just allows us to do the right thing by our patients and help them get their needs met.
Wonderful. Thank you for that explanation. So starting buprenorphine can be tricky. It can also be simple. There's so many different ways we do it, everything from rapid microinductions to macroinductions to traditional inductions. What do you like to use? How do you like to start buprenorphine in the office-based setting?
In general, I just try to use as plain language as possible. So I'm talking about I'm starting this patient on buprenorphine rather than I'm inducing a patient on a thing, because for me, the word inducing is always like, oh my gosh, I'm inducing labor, or something a little more tricky than I'm starting metformin. So I use the language in the same way that I would about cellulitis, and we have a treatment for that. It's called antibiotics. We have opioid use disorder, or we have cravings, or we have withdrawal, or we have pain, and we have treatment, and it's called buprenorphine. So I'm really just jumping ahead to the action plan that I have, which is starting treatment for opioid use disorder. A lot of times there's hesitancy on the patient's part to make a change in their life. Sometimes patients are like, oh my God, finally somebody's talking to me about this issue. I've been waiting for somebody to bring it up, especially if that patient's in withdrawal. If a patient is in withdrawal in front of me, I want to provide that medication as quickly as I can to that patient to reduce their suffering and help them be able to make more complex decisions with me. So I would be able to deliver a dose and administer a dose in my clinic. But most of the time, my patients are not in withdrawal, sitting in front of me with my own eyes, and I'm starting at home. And I just say, hey, this medication is super safe, super effective. We can start this at home today. Many of my patients want to know how to start buprenorphine, and the only sort of tricky thing, and it's tricky more for people who don't use opioids every day, but for my patients, it's not tricky at all, is to say, start this medication when you're in withdrawal. And that's the one thing with buprenorphine that you want to make sure you are doing. So buprenorphine is a partial mu agonist, which means if you start when you're actively intoxicated or actively on opioids, you're not going to have as much joy with that medication. In fact, you might experience a little bit of suffering, which is not what we want to cause our patients. So you want to tell your patient, hey, start this medication when you are in withdrawal. When do you expect that withdrawal to happen? And honestly, most of my patients can tell me to the minute when they think that withdrawal is going to happen. They can say, 2:17 p.m., I'm expecting to go into withdrawal. And then I say, awesome, 2:18 p.m. when you're at home or wherever you may be, please take this medication, put it under your tongue. You're going to feel well. Often, if somebody's like a little vague or not sure, I ask them, are you waking up in withdrawal? Do you feel miserable when you wake up? And a lot of times the answer is yes. I'm like, great. Instead of using your heroin, using your fentanyl, using whatever else you are, put the buprenorphine under your tongue tomorrow morning. You're going to feel well. And the job is that you feel like your old normal self again.
Wonderful. A lot of great themes there, right? Empowering the patient, letting them decide when and how to start the medication in a time and setting that works for them. Avoiding that word induction. Even though we've all been trained to use that, I do a lot of perinatal substance use disorder, and it is super confusing when I have a patient on labor and delivery and I say, hey, let's induce them. And all the nurses are like, we're inducing her? She's 28 weeks, right? So I agree 100%. Trying to avoid that term induction. A lot of great themes there. I appreciate that. Hey, here's the next question. This is a tricky one. I think we all struggle with this in the addiction world and in primary care as well. Fentanyl has thrown a wrench in the entire process and plan of how we treat patients with buprenorphine. It's made it more difficult, but it's also increased access and made the way we start buprenorphine simpler at times. So when we think about using different MOUDs and buprenorphine specifically in the setting of fentanyl, how are the various ways you like to start it? Home versus in clinic, the micro versus rapid. What do you like to use when you start buprenorphine in the setting of today's fentanyl crisis?
First of all, I want to acknowledge there's a lot of fear and myths and stigma around fentanyl. Just that word can terrify many of our colleagues and many of our friends and family members. But fentanyl is just like any other opioid. We use it all the time in the clinical setting. It's okay. We can manage this. So I just make sure I'm normalizing and not freaking out with my patient. Like, okay, fentanyl. I've treated many patients who use fentanyl. I have treated many patients who tell me they're the heaviest fentanyl user you've ever imagined. And so I agree with them. Probably you are. And we have a great treatment. It's called buprenorphine. I am a huge believer in making things really simple and stupid. So I start at 16 milligrams of buprenorphine under the tongue, which is 2 of those 8 milligram tablets. And if I'm having the patient start at home and they're leading their own healthcare, I tell them they can repeat that dosing as often as they need to until they feel well again. So I've had patients who take 16 milligrams when they're in withdrawal first thing in the morning, and they're well the whole day, and 16 is the perfect amount. I've had other patients need to repeat that dosing a couple times during the day We've noticed that fentanyl long-term heavy use seems to be a little more like longer-term withdrawal, even though it's a short-acting opioid. So over the first day, 2 or 3, it can be a little bit rocky of an on-ramp onto buprenorphine for my patient. And I tell them that. I'm like, this might be a great thing for you. 9 times out of 10, it goes wonderfully. It's simple and you feel well on that first dose. Every once in a while, you might need to repeat that dose. So if you're feeling like your withdrawal's coming back or your withdrawal's not completely treated, after about an hour, feel free to put another 16 under your tongue. There's no upper limit to how much buprenorphine a patient can take those first few days. It's completely self-led in my experience, and patients do much better than me trying to micromanage their dosing. They are so much more the experts of their opioid use disorder baseline, and then very much an expert on how to manage withdrawal, that if I can give them the teaching and the tools to start and continue buprenorphine, those first day, 2, 3, they are doing really well. Usually I preface this whole by saying, you might need a little bit more buprenorphine day 1, 2, 3, maybe even the first week, but usually by week 2, you're between 16 to 24 milligrams a day. That's 2 or 3 tablets a day. You can divide it up however you would love to. Some of our patients love to take something 3 times a day. Most of my patients, if I can get them to take one thing once a day, that's a miracle. So I do tell most of my patients to take the medication all at once. But if they're the kind of person that likes to split it up, I'm not going to argue with them. I'm building a therapeutic relationship and an alliance with them. Go ahead and take it how you feel like it's a safe medication to do that.
Wonderful, wonderful. Thank you. Again, patient autonomy and patient-led treatment. I really appreciate that concept. You keep beating home. And I think that's what we all have to take home from this is the patient knows themselves better than any of us do. And we need to empower them to take charge of that. Because oftentimes throughout addiction and substance use disorder, they don't have that control and they haven't been given that control. So thank you so much for emphasizing that point.
To learn more about Mood, visit CAFP's Homeroom, an online learning platform with online activities that's available 24/7 on a range of topics from reproductive health to chronic low back pain, ACEs to osteoarthritis. Visit familydocs.org/campus to find enduring activities that address so many aspects of substance use disorder and how to treat it as family physicians. To go deeper into how and why Mood is critical, visit familydocs.org/campus to find these accredited resources.
So let me switch gears a little bit and talk about another modality in starting MOUD. One of the other hats I wear is I run our backpack medicine project in Ventura County, where we go out and treat our patients that are suffering homelessness. And probably, let's say 80 to 85% of what we do is actually buprenorphine, is treatment of substance use disorders in the field. We do a lot of field-based starts. I'm curious, what have you seen that's worked? Do you think there's a role even for field-based starts of buprenorphine? And how do you approach that when you're dealing with patients that are suffering homelessness?
110% on board with this. So patients manage all their tasks of daily living in the field all the time, and taking a medication is just one more task that they are able to manage. So, of course, I want to support somebody's housing, stability, and all the beautiful dreams I have for them and they have for themselves. But often what's standing in the way of enacting those plans is a severe opioid use disorder. And when that's the case, again, we want to give patients the tools in hand at the moment we see them that can transform their lives. So for me, that's whether it's a telehealth visit and starting in the field, or whether it's somebody who I see in the ER that's going to be going back to their camp that's a mile away and they walked the way here. I'm making sure that they have buprenorphine, they have enough of the medication in their hand, in their pocket, to maintain treatment for as long as I think it'll be before they'll see me again. So I'm giving them at least 2 weeks, if not a month, on the first visit, because I want them to stay on this medication, and I don't want to be the barrier between them and a successful treatment start. So I think it's a great thing to be able to do in any and all settings, and I definitely hear you. I think a lot of our clinicians in our public settings and our low-income settings are seeing patients who have co-occurring behavioral health, mental health, all sorts of challenges, including housing, and making sure that we take one of those challenges off the deck, which is opioid use disorder. If we can treat that, this person's going to do much better in front of us.
Fabulous. Thank you. Next question. We have different options for our MOUD, medications for opiate use disorder. As primary care docs, of course, if we have our X waiver, we can use buprenorphine, but we also can use naltrexone without having an X waiver. And there is methadone available as well. So with 3 really good medications out there for opiate use disorder, how do you triage your patients to decide which patient you should offer which medication to?
So just to anchor us, we have methadone, which is a full-on opioid agonist. And the way that works is you're flooding the brain with opioids in a safe and controlled fashion such that a little bit more heroin is just not going to do anything because all those opioid receptors are already saturated. And then that breaks the cycle of use with our patients. On the flip side, the exact opposite of that is naltrexone. It's an opioid blocker. So the brain would not even see that heroin because all those receptors are blocked. And then in the middle, you have the queen of buprenorphine, which is a partial agonist. And the way that works is by stabilizing those receptors. So honestly, there's a lot of both regulatory frameworks and logistic frameworks that makes my decision to anchor towards the queen of buprenorphine the strongest and most frequent thing I go to. If somebody comes to me already on methadone, believe you me, I'm encouraging them to stay on methadone. If it's working for you, please continue. How can I help you? Do you need a ride to your methadone clinic? All those things. If somebody is agnostic to starting a treatment, I'm going to give them the option that gives them the most freedom, which is often the buprenorphine. There are times I look at naltrexone, and I think I speak more as somebody who has not personally experienced opioid use disorder. Naltrexone, you need to start as an opioid blocker when somebody's been off of opioids for a few days. My patients, if they could be a few days off of opioids, would not be my patients anymore. They would not be in the setting that I'm seeing them in. They might be a different setting. So naltrexone, you have to remember, is perhaps a little more viable in a controlled setting, in a monitored setting, in a setting where somebody has a lot of social support. One of the challenges with naltrexone is that you develop a brain that's kind of wiped clean or free of all these opioids. So the second somebody then stops taking their naltrexone for whatever reason, and we know our patients stop taking medications all the time for lots of reasons. When they stop taking naltrexone, it is a naive brain to opioids. They see the people, places, and things that remind them to use their substance of choice, and they take it at the dose that they're used to taking it, and they have an overdose event. So my experience with naltrexone is that it doesn't give the brain that kind of protection that buprenorphine does. Buprenorphine lasts a pretty long time. If you give a pretty consistent dose, 16 to 24, higher than that a day, that will last for 3 days, and it will protect against opioid overdose events, which is really useful when you have people living chaotic lives and they might forget their meds every now and then. So I am really a huge advocate of buprenorphine. Methadone, as you know, is one of the most tightly regulated things in the United States for a lot of legal reasons, and we know a lot of legal decisions are not made in science. So the reasons that methadone have regulations have little to do with the science, and I'm not going to influence federal change anytime soon. So I know that my patients who are interested in methadone should connect to a methadone clinic. I know the local one down the street. I'm friends with them. I refer patients to them, and I do my best to make sure that that patient shows up to that methadone clinic. But unfortunately, as outpatient providers in our community settings, we're not methadone clinics. We don't have those resources, laws, or authorizations to start methadone as a clinic-based provider.
Great. Lots of good points there, including there are lots of options for opioid use disorder, and we should offer all those options, like you said, and triage them into what fits that patient's accessibility the best. And the CAFP does a lot of great work with the legal aspect of it. So I don't know, maybe we will make a change to this, Rebecca.
You're optimistic. I love it. We can try.
I'm always optimistic. As long as we keep fighting the fight and CAFP's back there with us, we may see where this goes. Which there is great legislation coming up from both CSAM and ASAM as well on methadone regulation changes. So we'll see where that all goes.
Crossing fingers.
Do you use medication for your patients with opioid use disorders? You can be an MOUD champion and share your expertise with peers seeking to build medication opioid use disorder treatment into their practice. CAFP is building an MOUD champion network. Visit CAFP's research page for addiction and substance use disorder, familydocs.org/SUD, to sign up today. That's familydocs.org/SUD.
Okay, cool. So Rebecca, next question. We both wear 2 hats. We're both family doctors. We're both addiction specialists. And I oftentimes am trying to train my family medicine residents on who they should be able to manage with a substance use disorder and when they should triage that patient out to an addiction specialist when it's beyond their scope. How do you teach family physicians and other primary care prescribing providers to identify which patients need to be sent to an addiction medicine specialist and which can be treated within their own purview in their clinic?
I think you and I both share this belief that family medicine doctors can and should do everything as much as we possibly can. And so when I start hearing the word specialist, my first link is to the word limitedist. If I want to send my patient to a limitedist who's only going to look at this one part of their life, then I need to do that. But I want to make sure this patient has comprehensive care, including all the things that we are amazing at: contraception, PrEP, STD treatment, Hep C, HIV, all those things too that make family medicine doctors these wonderful souls in our communities. So I am of the strong preference that if you have a patient in your practice on your panel, you keep them on your practice and in your panel, and you treat the opioid use disorder as problem number next on your list, just like you would for contraception care, pap smears, mammograms, breast cancer screening, all those things. It's really that easy. Once in a while, you may encounter a situation where maybe you're in a gray zone, you're not sure, there's a lot of ambiguity, you want just another opinion, is this going on, is that going on? That might be a great time to call an addiction specialist. I often provide my contact information and say, hey, sometimes just that first case, you're like, I don't know, could this be the one? And the first time you prescribe buprenorphine, just like the first time you do anything, can be a little scary. So I'm like, phone your friends, call us. We love to talk to you and we love to tell you, yes, that's the best case I've ever seen. That's a classic case. I have yet to have a family doctor call me up for their first script and give me a case that is not an appropriate case for buprenorphine. They are generally erring on the side of undertreatment rather than overtreatment. So we're here for you. We're here to support your decision-making, support your primary care panels in any way you can. What do you do? How often are you sending somebody to a specialist?
What we try to teach in our practice for our family docs is to really manage it, just like you said, as much as they can, empowering them, because these grads are going to go out into underserved settings, rural settings where they're really it. There is no addiction specialist. We're so limited in numbers still. How many of us are out there? So I try to really get them to understand that if you get to the point where your dosing isn't working, or you've got a significant co-occurring use disorder or psychiatric disorder where you're concerned about oversedation with other meds, for example, someone might be on a big dose of benzos they're getting off the street as well. Those are ones that it might be worth sending to us for a consult to help you with the taper plan, etc. But we try to empower our trainees to understand that they can manage most of this on their own, and just having that friend they can kind of phone and say, hey, what do I do in this case? And there's a lot of great programs out there like the ECHO programs, et cetera, for substance use disorder, the California Hotline, the UCLA STAR program that provides tutoring as well. So a lot of great programs out there for them. But I agree, it's all about empowering primary care docs. And one of my partners who just retired and one of my mentors, Dr. Leslie Lynn Pawson, always said that palliative care is just good family medicine. And so I stole that tagline and I use it all the time with my addiction fellows and with my residents. I say addiction medicine is just good family medicine. So I am 110% behind everything you said, Rebecca.
Yeah, and we know that addiction is very common. It happens friends and family and providers alike, as well as our patients. So it would be ridiculous if you were to think, okay, anybody that has addiction must go to a specialist. I don't think anybody's actually saying that. However, I really think primary care medical homes is where both patients want to be seen. They're welcome into our world. We're welcome into their world. There's already an existing relationship and rapport. And to offer the enhancement of providing addiction care in an excellent way is just an added bonus for our patients and for our community.
So let me segue into our last question here that I have for you today. And I think this hopefully will put it all together for our listeners at home. What would you say to family doctors who, after hearing all of this, are still on the fence about offering MOUD or medications for opiate use disorder to their patients with opiate use disorder?
I would say a couple of things, some stories. So I have treated patients in the ER and urgent care setting and spent 5 minutes with them being like, oh, boo, it looks like you have this abscess due to injecting your heroin. I would love to give you treatment for your abscess and also treatment to help you stay away from heroin because I know that's been rough for you. And here's the script for buprenorphine. Literally about like that much time I spend with that patient because there's 500 million other things to do that day. And that patient will take my script, fill it, take that medication, not be in withdrawal, be able to live a healthy life, get back into school, reconnect with their friends, family, and loved ones, get a car, all the things that are super important in LA. And then I'll see them 3 months later because I gave a refill because you can with buprenorphine. And I just started getting in the habit of writing a refill. And they'll say, hey, remember me? You won't believe it. I have a car now. My grandma lent me money for the first time in 10 years. And I'm like, I don't remember you at all because from my experience, it was just so simple and so straightforward. Of course, that's not what I'm telling my patient. I love my patients and I'm very encouraging of them to tell me those great stories. But there is no other thing in medicine at all that I take 30 seconds to start a treatment, 30 seconds to write a prescription, and connect with that patient, make sure that everything's going well, and then send them out the door safely and confidently, and they come back with these stories of transformation and enjoyment of their life. And that is something that keeps me in the game, keeps me going, and really want to encourage other people to feel confident in starting that journey.
So in your setting in urgent care, how long does it take you on average to see a belly pain or a vertigo or a runny nose, cough, etc.? What's your average patient visit time?
Yeah, that's always the challenge of primary care and urgent care is a dizziness could be something simple and it's going to take you 10 minutes, or it could be something so complex and you're still trying to figure it out. And this patient's 87 and there you are 3 hours later, still trying to manage this patient well. The amazing thing with buprenorphine and medications for opioid use disorder is that honestly, that patient's honestly telling you often what's going on. I have problems with opioids. I want treatment. Done. You write the treatment. That could be as little as 5 minutes, 10 minutes. Honestly, when I see those patients on my track or on my panel, I'm like, great, I know what's going to happen. This is going to be simple and I love it. I have a solution. I can do something.
Yeah, wonderful. I totally agree. When I look at my schedule in clinic and I see what's coming up and CKD and, heart failure and, all these things, I know I'm going to be in there for a while to then go, oh, thank God. An OUD follow-up. Okay, this will be quick.
Exactly.
Yeah, so I think you're right. It's really nice having that as a break and really helping us remember that this is a easy problem to treat and it doesn't take as much time as a lot of the other things we do in primary care.
Yeah, and I do want to preface this by saying it is hard for our patients. It is hard for our community. These are serious diseases that need a lot of love and support and attention and all the different modalities because people's lives are complex. But that's not about the treatment decisions that I'm making as a physician to treat opioid use disorder. That part of my day is easy, quick, and simple. And of course, I want all these other gorgeous things for all my patients, and I'm going to connect them to all those services. But that on my track with the problem list is like, oh, great, simple diagnosis, simple treatment.
Hey, so Rebecca, remember back in the day, one of the requirements to prescribe buprenorphine is we had to connect and document that we connected patients to some type of behavioral care. It could have been a NA meeting or a counselor, but we had to document that. That was what was beaten into our heads. That's changed over the last few years, and now it's no longer a hard set in stone requirement. What are your thoughts about linking people to behavioral care or even delving into a behavioral health history when starting buprenorphine in the primary care setting?
Having a medication-first model of care is critical to being able to treat our community and treat our patients well. So making sure our priority is meds in mouth, have your pills in your pocket, and make sure that happens no matter what. That's number one. Number 2, 3, 4, and 5 is, of course, all those other things that we love to do as family docs, right? Like, of course, I want to know how I can help you richly take care of yourself. And we know that a lot of our patients in our low-income areas are struggling with ACEs and backstories and complexities and legal histories and all these things. And I'm here for that too. And at the same time, that's not going to get in the way of medication first, making sure that those patients are alive to be able to talk about those issues and to connect to the people they want to connect to, and not forcing somebody to talk about their trauma history just to get an effective life-saving treatment.
So one of the other hats I wear is I'm an ER attending in a level 2 trauma center. So we do a lot of BUP starts in the ER, and then I set them up to be seen through our substance use navigator into the Bridge program, which is also our own clinic on the other end. But you are a leader in the Bridge program. Can you share some tips or best practices for those primary care docs that are both working in the ER and starting buprenorphine in the ER, because a lot of family docs work in the ER, of course, or urgent care setting. And then for the receiving end, so then as they transition into a primary care practice, for those receiving those patients and how best to harmonize and bridge that treatment gap?
Yeah, that's a great question. The transitions of care is something that I think family medicine doctors are amazing at. And also, it's one of the biggest challenges in our day-to-day life. So as a hospitalist, I want to make sure that this treatment plan is continued in the outpatient setting and modified to optimize my patient's health that I might not even understand in the 1 or 2 day stay that they have in the hospital. Same thing in the ER. I want to make sure that the treatment is started and effectively communicated so that they can follow up with a great complexivist who's a primary care doctor who can do all the great things. The most important thing is to make sure that these diagnoses are clearly communicated in the chart. The medication is prescribed for long enough. You're making sure that you're not being overly cautious, but giving that person the supplies to make sure that they will take medications, have them available to them until they can call their insurance, figure out who their clinic is, make that follow-up appointment. But the kids are sick, the bus is late, so they didn't make that follow-up appointment, and then 2 weeks later they show up. Like, we know our patients' lives, it's hard to get from place to place, so we gotta make sure that across all these care settings, we're able to communicate well with our patient how important it is to continue buprenorphine, do our jobs right on day one. So if we're in the urgent care, if we're in the ER, if we're in the hospital, prescribing those discharge meds, putting in refills, and telling the patient that this is the most important thing that they can do at their follow-up visit is show their doctor this bottle of pills so that that doctor can continue that medication. That's our jam as family doctors. We can do it all.
Very cool, Rebecca. Well, let's end with this. Let's play a game real quick. I'm going to ask you which is easier, which is harder, since, again, you're a primary care doc and an addiction doc. Treatment of OUD or hypertension?
Opioid use disorder.
All right. OUD or diabetes?
Opioid use disorder. I'm literally telling you, it's a pretty simple game.
Well, I'm still going here. Opioid use disorder or contraception?
Depends on the contraception. If it's an IUD, I might be favoring like a Mirena IUD over this one. But what's amazing about buprenorphine is you do have that long-acting monthly injection available. So if you're saying buprenorphine or Depo-Provera, I'm going to say, maybe buprenorphine because there's a lot more,
All right. All right. Well, let's shake it up a little bit. How about opioid use disorder or testosterone replacement?
Ooh, those are both enjoyable to start quickly. I think opioid use disorder has a bigger reward for my patient and myself. So I like doing it. I favor it, but especially for my trans community, starting testosterone is pretty straightforward. But I don't need to get labs for buprenorphine. I don't need to check anything. I am just having a discussion with my patient, making a diagnosis, and starting treatment. That's the best thing about being a family doctor, is building a diagnosis off of that conversation.
Wow, you just told me that treating opioid use disorder with buprenorphine in your clinic is easier than everything else in family medicine. So I think that's a great place to end as we all kind of wrap this together in how we can be leaders in our clinic, in our field, as primary care physicians practicing up-to-date evidence-based opioid use disorder care. Thanks, Rebecca.
Thank you, Tipu. Have a wonderful day.
You as well.
I hope you enjoyed the useful, practical information shared here about recognizing and diagnosing addiction and about starting and managing treatment. I'd like to reiterate something Dr. Trotsky said, because it's absolutely true in my experiences too. Treatment for addiction medicine is one of the simplest medical decisions I make in my busy day. And we already know from our prior podcast sessions that it also represents some of the most rewarding experiences in our day. The complexities of treatment should absolutely not be something that stops you from offering MOUD. Guess what? We're entering the home stretch in our series, Treating Addiction in Primary Care. And I hope you can join us for our fourth and final podcast. Addiction medicine is family medicine. Family Docs podcast and the Treating Addiction in Primary Care series is brought to you by the California Academy of Family Physicians, the largest chapter of the American Academy of Family Physicians, and the only organization in California solely dedicated to advancing the specialty of family medicine. To find out more about CAFP, visit familydocs.org. If you enjoyed this episode, please share with your colleagues, rate and review us on Apple Podcasts or your favorite podcast program. And be sure to come back for more. To find more resources about MOUD and substance use disorder, check out our webpage at familydocs.org/SUD. The Family Docs podcast was developed, produced, and recorded by the California Academy of Family Physicians. Support for Treating Addiction in Primary Care series is provided by the National Institute on Drug Abuse and the California Department of Healthcare Services. Thanks to Shatterproof for sharing ambassador voices. Until next time, this is your favorite family physician, Dr. Rabah Sibe with CAFP.